So I'll just press the record button now, and then I'll share my screen, and we'll see how we go. I'll be letting people in as they come in or as they join, but let's make a start. Look, today we have a number of people on this lecture. We've got Geraldine Lagani from Gerahu, so welcome. Wilma Luan from Madang, some folk from Honiara, so welcome Matthew and Hicks, I think, and perhaps John's there, and Dr. Vilawatch and Gamini Valley and Dr. Kilalang from Port Moresby General Hospital, and I think Alan Herrero is here from Alatau as well. So it's a good number of people, and as I say, more people will come in as we go. But let's make a start. I wanted to talk today. I think there's some fundamental things that we need to know about neonatology, and so I wanted to start off by talking about the care of the very low birth weight baby, because I think this is something that challenges us all, and it's quite complicated. It's quite complicated to look after a sick, very low birth weight baby, and I want you to be experts in that. I feel that when we've improved the care of very low birth weight babies, we generally improve overall neonatal care. And if we get the care of these babies right, the moderately preterm and very low birth weight babies right, then I think it teaches us a lot about how to look after sick newborns. So we'll start now. You might know this, but around about 15 to 20% of all babies born in Papua New Guinea have low birth weight, and of course low birth weight is less than 2.5 kilos. But yes, 15 to 24%. So there's many different studies that have been done. Some are hospital studies, some are community studies, but around about that. So it's a big issue. It's a big problem. It's a problem that we have to deal with a lot. And around about, again, depending on the studies, about 6.6 to 18% are preterm. As I say, the variation between the studies of low birth weight and prematurity relate to whether they're in a hospital setting or a community setting or district hospitals or tertiary referral hospitals, because the proportion of very low birth weight children differ in those settings. But suffice it to say, I'll just admit some more people now. Suffice it to say, it's a very big problem. We need, as paediatricians, we need to be really good at managing these patients. So that's just an issue of the burden. You need to have a good understanding of definitions. So for those who are like Diploma of Child Health candidates or Master's candidates, you really need to have a good understanding of what low birth weight and very low birth weight and extremely low birth weight mean. And so low birth weight is anything less than 2.5 kilos, 2.5 kilograms. Very low birth weight is a baby born, a birth weight between 1,000 and 1,499 grams. So it's this group that I think is, if we make big gains in the management of these patients, then I think we learn a lot about neonatology and a lot about how to look after sick newborn babies. And then there's the much less common proportion of babies that have extremely low birth weight, less than 1,000 grams. And it's true to say, if you make gains in the quality of care for very low birth weight babies, then these extremely low birth weight babies are more likely to survive. But I think our aim should be to try to get as many of these very low birth weight babies surviving and thriving, not just surviving, but thriving with minimal morbidity. That's what the challenge of the management of the very low birth weight baby is, not just to get babies to survive to hospital discharge, but to get them thriving and free and relatively free of comorbidity.
No, they're just going to stop. Vince already recorded the video. We're just going to
Could I ask if you could possibly mute your device? Thank you. That's good. So that's the definition based on birth weight, and then there's the definitions that are based on the completed weeks of gestation. And so a preterm baby, I'm sure you all know, is less than 37 weeks of. I'll just admit some more people now. A preterm baby, of course, is less than 37 weeks completed weeks of gestation. That's not to say that the baby born at 38 weeks or 39 weeks can't have some problems too, related to relative immaturity, but most of the problems occur in babies that are born less than 37 weeks completed gestation. Then there's preterm is then divided up into two other categories, and this is sort of important because those babies that are born between 34 and 37 weeks, those that are what's called late preterm, they have somewhat different problems to babies that are early preterm babies, like less than 34 weeks. And many of the very low birth weight babies fall into the category of being early preterm, don't they? Sort of they're 32 to 34 weeks, sometimes 30 to 34 weeks. And so, as I say, the problems are a little bit different in terms of feeding, in terms of the proportion that have respiratory distress syndrome and other issues. Then there's the classification of small for gestational age. And this is a little bit different still. It's a combination, if you like, of the gestational age and the weight. And I think this is a useful graph. So, for example, if you had I'll just admit Anna, who's coming in. If you have a baby born at 36 weeks gestation who's 1,400 grams, then that baby is small for gestational age. They're both a bit preterm, aren't they? They're a late preterm, but they're very low birth weight, so they're small for gestational age. On the other hand, if a 32-week gestation baby was 1,400 grams, then that baby would be appropriate for their gestational age. They wouldn't be small for gestational age, they'd be appropriate if they were 32 weeks gestation. This helps us somewhat in understanding the combination of complications that babies with low birth weight and prematurity can have. And so it is important to try to try to calculate the gestational age. And I want to give a couple of ways in which that can be done. They're not so simple, but there's probably one method that is the most useful. And they're clinical examinations in terms of assessment of gestational age of a newborn baby. The first test, the first type of this assessment was called the Dubowitz score, and many of you will have heard of the Dubowitz score. This was designed in the 1970s, early 1970s, and it's quite a complicated score, as is the one I'm going to talk about, the Ballard score. But I think we should get good at doing one type of score, and I think if in most places the Ballard score has superseded, if you like, the Dubowitz score. They're both still useful and they tell you similar things, but I think the Ballard score is a bit easier to use. And so I would concentrate on that. Again, it's along similar principles of the, I'll just admit a couple more people here, but the Dubowitz score and the Ballard score have what's called neurological criteria and what's called external criteria. And so the neurological criteria are really looking to see what the tone of the baby is, what their degree of flexion is. I'll just admit some more people as we go. What their degree of flexion is, what their elastic recoil is. So it's all about the relative balance between flexion and extension and the tone the baby has. And then the external criteria I'll explain when we talk about the Ballard score. But this score was designed, as I say, in the 1970s. It was the first attempt to try to assess a preterm baby to see how preterm they were. And it actually is very accurate. It's very accurate to around about 1 week, even when you use the last known menstrual period in mothers that for which that is known accurately, and it's accurate in assessment of gestational age against ultrasound. So ultrasound again is another useful method for identifying gestational age in a late fetus in late gestation. But the Dubowitz score and the Ballard score are very accurate in assessing that. The Ballard score, as I said, it looks very similar, doesn't it, to the Dubowitz score, and it looks at a number of what so-called neurological features or neuromuscular features. They call them neuromuscular maturity, and I think that's even a better description, because it's looking at the relative the posture. Now, the posture is really how the baby lies, isn't it? And you know that a term baby will have a much more flexed posture than a very preterm baby. The square window is the when you do that with the baby's wrist, then it's the angle that the thumb makes with the forearm. That's called the square window. The arm recoil is simply just moving the arms up and seeing how much flexion there is to pulling the arms forward and seeing how much flexion there is. I'll just admit some more people. And you can do this by examining the baby just lying down. You just pull up their arms and see how much elastic recoil there is. A preterm baby, they'll have almost no elastic recoil. You pull their arms up and then they'll just flop down if they're, say, less than 30 weeks gestation. But a term baby, they'll have elastic recoil with a lot of flexion at the end. The popliteal angle is rather similar, picking up a baby's foot and trying to put it onto the baby's ear and to see what the angle is made by the popliteal, by the popliteal angle, and that's the angle around the knee. And a term baby will have more flexion, so they'll have more tone, whereas a preterm baby, you'll almost be able to get the baby's foot up to the baby's ear. The scarf sign is rather similar, taking the baby's hand and moving it across the baby's chest. And again, the baby that has more flexion, that is the term baby, where you won't be able to move their arm right across the chest, whereas a preterm baby, they're rather floppy and you can move it right across. These are all markers of tonicity, aren't they? So the more hypertonic, the higher the tone, the more mature the baby is, generally speaking. And the heel to ear sign is rather similar, trying to put the baby's heel on the ear. It's similar to the popliteal angle, but it's just looking at a different thing. And then there are markers of physical maturity. It seems like a lot of things to look at, but it's not really hard to do. You're just simply examining the neuromuscular state of the baby to start with. Then you're looking for this lanugo, which is very fine hair that babies have, and when a baby's term, they have very, very fine light hair. When they're very preterm, they have nothing, and actually their skin is rather more sticky, and often if they're very preterm, it looks rather transparent. And when they get to be post-term, then often that lanugo hair is lost. The plantar surfaces and the degree of skin creases, babies who are very preterm have almost no skin creases on the soles of their feet, whereas babies who are term or post-term have a lot of skin creases. They have skin creases all over their feet. The breast bud is imperceptible. It's not palpable in a preterm baby, and by the time the baby is term, then you can feel the breast bud. And again, if a baby's post-term, then they have an even more palpable breast bud. The ears and the eyes are the next part, and the ears are really loose and have little cartilage in a very preterm baby, and they're more firm, aren't they, in a baby who's term, and just as the cartilage matures and becomes stiffer. The genitals, again, for males and females, it's rather similar. The scrotum is flat in a very preterm baby, and it's hard to feel the testes in the scrotum until a baby's close to term. But these are just things that you can assess to. It all adds up to whether or not the baby's very preterm or term, late preterm or post dates. And similar for the female genitalia. I'll just admit some more people. For the female genitalia, they become more mature as the baby gets older. And you can assign a number to each of these. So if the baby, for example, has moderate flexion, and if they score a 2 in these neuromuscular areas and a 2 in all these, then that's 2, 4, 6, 8, 10, 12, 14, 16, 18, 20, 22, 24, 26. And so that baby scoring 26 would be around about 34 weeks gestation. And of course, a baby might not score in the same column for every one of these, but you add these up and then you can tell from this score what their gestation is. And the Ballard score has been shown to be accurate really to about 1 or 2 weeks gestation based on the gold standard, which is ultrasound or an accurate understanding of the last known menstrual period. So just to go through these things again, the criteria, the neurology or neuromuscular maturity, how the baby holds his or her arms and legs, how flexed they are, The square window is how far the baby's hands can be flexed towards the wrist. The arm recoil is how far the baby's arms spring back to a flexed position when you just try to lift the baby up from a lying position. The popliteal angle is how far the baby's knees extend, all right? And the popliteal being the knee, just the undersurface of the knee, how far the knee extends. Remember, a term baby, they'll have more flexion. A preterm baby will be more hypotonic and won't have that degree of flexion. The scarf sign, remember how far the baby's elbow can be moved across the baby's chest, and the heel to ear, whether the baby's feet can be moved towards the ear. Remember, the preterm baby with low tone who is more floppy, the heel moves closer to the ear. That's the neuromuscular maturity scores. Just going to let some people in now. The external features of the Ballard score, remember, a baby's skin goes from just feeling a bit sticky and transparent to being really smooth, and then a post-term baby will often have peeling skin, won't they? The lanugo is that soft downy hair, absent in preterm babies. It appears in maturity and disappears again with post-maturity. The plantar creases are absent in preterm babies, and they cover the entire foot if a baby's post-mature and usually a mature baby. The breast, the thickness and size of the breast tissue and areola, the darkened sort of ring around each nipple, indicate whether the baby's preterm or term. The eyes and ears, a preterm baby has fused eyes and floppy ears, and of course, a term baby has open eyes, and I'll just admit someone else, and stiffer ears because the cartilage is stiff. And the appearance of the testes and the appearance of the testes within the scrotum, and the skin appearance of the scrotum from very smooth in a preterm baby or flat to being wrinkled in a term or post-term baby. And the in a female, in a girl, the appearance and size of the clitoris and the labia are important in determining maturity. Okay, that's all I want to say really about the assessment of maturity. And again, mostly we often don't do this. We often just assign a birth weight to these babies, but I think it's useful really to try to do this, the Ballard score in more babies, so we get a feel for the degree of maturity of the babies that are low birth weight and very low birth weight. I wanted to now focus a bit on the problems that a very low birth weight baby has. So I've just tried to draw all these problems. I haven't drawn them all, I don't think, but these are if you think about a preterm, very low birth weight baby, they can have almost every organ can be affected by some sort of problem that occurs in the postnatal period. And so I just think in terms of each organ, what are the complications? And so, as you know, in the brain in very preterm babies, all the organs are immature, aren't they? They're all immature, and there's lots of reasons why complications can occur, but preterm babies can have intraventricular hemorrhages, and they can end up with, and those intraventricular hemorrhages can be just a little bit of bleeding within the ventricle, or it can spill out into the brain substance itself, and that can lead to a condition called leukomalacia, or just a sort of softening of the brain tissue and scarring of the brain tissue that can occur over time, usually in a very focal area. But of course, all that can lead to some developmental problems in babies. And preterm and very low birth weight babies are a bit more prone to other problems, such as perinatal asphyxia as well. And so both perinatal asphyxia and intraventricular hemorrhages are complications that these babies can have. I only mention this first, not because it's the most common one, but it's something that we really need to be aware of. I'll talk a bit more about these in a little while. Then if you go to the eyes, retinopathy of prematurity and the effect of oxygen therapy on that is really important for us to understand. If you go to the chest, then respiratory distress syndrome, what used to be called hyaline membrane disease, the lack of surfactant in the lungs is a common preterm, very low birth weight problem. Also, other respiratory problems like apnea is very common in these babies. The A patent ductus arteriosus is also, if you go to the heart and the cardiovascular system, that's very common in preterm babies, especially those that have moderate to severe RDS. In the gastrointestinal system, feed intolerance is almost universal, isn't it? Babies, you know, a bit slower to tolerate enteral feeding, and at the most extreme form, babies can have this infection called necrotizing enterocolitis, which I'll talk a bit more about as we go along. I'm just really trying to outline at this stage all the different problems that these preterm and low birth weight babies have, and then we'll talk about them in a bit more detail. Later on, babies who have respiratory distress syndrome or who are preterm can get bronchopulmonary dysplasia or chronic lung disease related to prematurity, and I'll explain what the definition of that is. They can have their bones also. This is actually a big and often under-recognized problem in preterm babies, that they can have osteopenia of prematurity, where they have reduced bone mass, and because of that, they can have, well, they often have impaired linear growth. So this can be exacerbated by, partly it's because they have immature bones when they're born, but it can also be exacerbated by other treatments that we might give, such as diuretic therapy or steroids. And if they have vitamin D deficiency, that's very important as well. They have immature kidneys, and preterm babies can't really tolerate a solute load very well, so they can't really handle a lot of sodium because their kidneys are just a bit immature to start with, if they're less than 34 weeks particularly. They often have, well, boys often have inguinal hernias. That's not uncommon. A patent processus vaginalis, and sometimes those inguinal, you just need to be aware of those. And in our examination of a preterm or very low birth weight baby, we should be trying to examine for all of these things. Then they're prone to anemia, as I said, apnea, systemic problems. So anemia, apnea, hypothermia, hypoglycemia, and then later on developmental delay. And so I think when we are thinking about preterm and very low birth weight babies in our examination, in our history taking, in our understanding of the child's sort of past history, we really need to have a good understanding of to what extent did the baby suffer from any of these complications. Okay. Having explained all the complications that a preterm or very low birth weight baby can have, I think the management of a very low birth weight baby is relatively straightforward, and that is we need to keep their temperature within the normal range so they don't get too overheated and they don't get cold, because if they get overheated or cold, then they'll be expending more energy to maintain normothermia. So maintaining their temperature within a normal range is really important, 36 to 37 degrees. If they need oxygen, because many babies have respiratory distress syndrome, then it's fine for them to get it, but we need to be clear about the targets. And that's why I think that pulse oximetry is an essential tool for managing preterm and very low birth weight babies, because we really should be targeting not just above a certain level, but also below a certain level. And our target should be 88 to 95%. It should not be higher than 95%. And if you see a preterm baby that has a saturation of 100% and they're on oxygen, then that should be an alert. We should really be alerted by that to do something about it, as in to stop the oxygen. If you've got a preterm baby who's not on oxygen and their saturations are 99 and 100, that's fine. There's nothing wrong with that. But we shouldn't be pushing their saturation above 95% by giving them oxygen, because of the risk of retinopathy of prematurity. I'll explain a bit more about that in a little while. Again, I just wanted to outline the basics of management of very low birth weight babies, because I think the basics are quite simple. We need to keep them warm. We need to keep them pink, but not with high saturations. We need to keep we need to initiate breast milk feeding, including colostrum, so via a nasogastric tube if they can't suck. So the initiation of feeding, I'll explain about that at some stage. If they can't feed, then giving them a glucose source is important, and ensuring that they don't get too much fluid is very important if you're giving intravenous fluids. Again, I'll talk a bit about that. Preterm babies are very prone to apnea, And I think the use of aminophylline or caffeine, if babies have apnea, can be very important. There's other ways you can manage apnea for using CPAP is also a way of managing it. But I think for most babies who are preterm who are having apnea, first of all, we should ask the question why they're having apnea. Is it just because of apnea of prematurity, or is it some systemic problem such as anemia or a PDA, or they've got necrotizing enterocolitis, or they're hypothermic, or they're hypoglycemic, or they've got intraventricular hemorrhage? All of those things that I mentioned before can manifest as apnea in preterm babies. So any preterm baby that has apnea, we really should be thinking, well, what complication do they have? Or is this just because of their immaturity? If a preterm baby has signs of infection, then we need to treat it with antibiotics. This is the early management if they have signs of infection. And the signs of infection, could be that the mother had a high fever and the baby and the liquor was meconium stained, or the baby has a fever. Any signs of infection we should treat. And if we are giving benzoyl penicillin and gentamicin, then we're covering most of the bugs that will cause infection in preterm babies. That's not hospital-acquired infections, but these are the bacteria that will cause early neonatal sepsis, typically group B streptococcus and gram-negative, such as E. coli. If they're jaundice, then they need phototherapy. Perhaps we'll talk about that at another time. And all preterm and low birth weight babies still need vitamin K to prevent intraventricular hemorrhages, or reduce the risk of intraventricular hemorrhages and other bleeding. And they also need their standard vaccines. And some people think that it's not safe to give vaccines to preterm babies, but it is. There's been good studies done to show at least at 34 weeks, it's quite safe and just as effective to give BCG vaccine. In fact, it may be, it protects them against some complications of prematurity. So I certainly give BCG vaccine and hepatitis B vaccine to all preterm babies from 34 weeks gestation onwards at least. Okay. Now I want to show now a few x-rays, and I wanted to, in a way, explain why it's sometimes quite hard to tell the difference between different conditions, and looking at an x-ray won't always tell you what the underlying problem is, but knowing the history can help you understand. So for example, I've got 4 x-rays I'm going to show, and there's a clinical case vignette, or a case description. And so this was the baby in A, this baby here was a 1.2 kilogram baby and born by normal vaginal delivery. In the first hour developed tachypnea, so a respiratory rate of 70, had grunting and an oxygen saturation of 82%. There was no prolonged rupture of membranes and no maternal fever. What do you think's going on? This x-ray was taken around about 4 hours of age. What do you think's going on?
Acute respiratory distress syndrome.
Yes, most likely, that's right. Most likely this baby has respiratory distress syndrome. Now, if this was a different description of a child, if this was a 6-month-old baby with that x-ray, what might you think was going on? What might you suggest?
It was a 6-month-old with generalized haziness. I would be thinking, probably PTB.
Yes, that's right. Yeah, with this x-ray, if you thought that if the baby was 6 or 12 months of age, you might say this looks like miliary TB, but in fact, that's why the history is so important. This is a typical x-ray of a baby who has hyaline membrane disease or respiratory distress syndrome. I've just put a normal newborn x-ray for comparison, and you can see how translucent the lung fields are. They're black, but you can see some bronchovascular markings in the lung fields. They're not completely black, whereas here there's a diffuse what we call ground glass appearance. You know what if you use a grinder on glass and you grind it, then it gives this hazy white appearance to the glass, and that's why this is often called a ground glass appearance. It's not quite a miliary appearance, it's a ground glass appearance, but it's a diffuse opacification. And it all relates to the collapse of alveoli throughout, fluid-filled alveoli throughout the lungs. So that's the first X-ray. The second X-ray, B, can anyone, well, a 3.4 kilo baby was born 1 week post-term by cesarean section. In the first hour developed tachypnea, so respiratory rate 70 and an oxygen saturation of 88%. There was no prolonged ruptured membranes, there was no maternal fever, and this resolved within 24 hours. What do you think's wrong with this baby?
PTM.
I'm sorry, say that again, Manu?
TTN?
Yes, that's right, yeah. Again, the history is important, isn't it? That the history that the baby was born by cesarean section, because babies who are born by cesarean section are much more prone to transient tachypnea of the newborn. But if this was a 800 or 1200 gram baby, and this was the first X-ray in the first couple of hours of life, you could say that this was the early stages of development of hyaline membrane disease. But it's because you know that the baby is a term baby born by cesarean section, that there's mild hypoxemia, no prolonged ruptured membranes, no maternal fever, and it resolved over 24 hours, then by definition, this is transient tachypnea of the newborn. The third X-ray, this was a 2.1 kilogram baby, again born by normal vaginal delivery after prolonged ruptured membranes of 36 hours and a maternal fever. The liquor was discolored. The baby was grunting and tachypnea developed at around 6 hours of life, and the temperature was 38.2. What do you think is going on here?
Probably neonatal pneumonia.
Yes,
there's no
that's
mention
right.
of.
Yes, that's right. Because it's a baby born, could be a little bit preterm, but born by normal delivery with after prolonged ruptured membranes, and there are signs of infection. There was maternal fever, the liquor was discolored, the baby was grunting and tachypneic at 6 hours of age. And this X-ray appearance, this was a baby who had Group B streptococcus pneumonia, and that's all the baby had. The baby didn't have preterm RDS and didn't have any meconium staining. It was this is just the X-ray of a baby with Group B streptococcus pneumonia. And again, the history is so important. If you saw this X-ray in another baby of a different age or with a different history, you could come to a different conclusion. So that's why you need to ask these questions and try to make a distinction, not so much on the X-ray, but on the history. The other feature of this X-ray that I think is important is, and the next X-ray I'll show will be a bit different. If you look at the lung fields, the lung fields look relatively small, don't they? You can see that the baby is not hyperinflated. The lung fields are relatively small. And when you've got pneumonia or when you've got respiratory distress syndrome, then the lung fields look relatively small. There's much less aeration of the lungs. This X-ray is a bit different. And so this was a 2.6 kilogram baby born by cesarean section for fetal distress. The baby was floppy at birth and covered in thick meconium, was tachypneic and grunting, and was hyperinflated. You can see that the lung fields look a bit hyperinflated and there's crackles throughout. And so what do you think, what could be going on here?
Meconium aspiration.
Yes, that's right. Yes. Meconium aspiration, and there are some characteristic radiographic features of this. I mean, it doesn't look like what I showed you before, that ground glass appearance, does it? The opacities are more coarse. They're generalized and they're more coarse, and the baby has hyperinflated lungs, as opposed to very fine opacities here, where the lung fields look a bit smaller. All right. So respiratory distress syndrome is a small lung volume disease where the lungs are a bit collapsed, aren't they? All over the alveoli are a bit collapsed because they're full of fluid or they're collapsed. Whereas meconium aspiration is what we call a large lung volume disease where there's hyperinflation. Why? Because the meconium is often blocking the small airways, the bronchi and the bronchioles, and causing hyperinflation. And so there are some distinctions you can make based on the X-ray, but the history is all important in terms of understanding the cause. So these are 4 causes that you often have to distinguish when you're looking after these babies: hyaline membrane disease, transient tachypnea of the newborn, neonatal pneumonia, and meconium aspiration. And and you can do that. You can make that distinction based on the clinical picture, asking the right questions, and also based on the X-ray findings. So I framed the cases in this way because these are like these are like extended matching questions, and for those who have done their diploma of child health already, you'll be familiar with extended matching questions. But really, extended matching questions are commonly given in the exam. They're given in all the exams, in the diploma exam and in the master's exams, and what you're given is a clinical scenario, and you have to try to match it with a diagnosis, right? And typically there'd be 5 or 6 clinical scenarios, and you'd match it with 5 or 6 diagnoses, all right? And so, which is the process that you just did then, looking at the X-ray and matching the most likely diagnosis. I'll send this around, but for those who are doing their DCH for the first time this year, you'll need to become familiar with with extended matching questions. They're quite easy and they're sort of fun to do. That I think they can teach us a lot about making clinical diagnoses based on detailed histories. So I'll send that around. Okay. Well, look, the management of lung disease in preterm babies, we've talked about hyaline membrane disease and respiratory distress syndrome. I think there's just a few points I wanted to make about the management of lung disease. I'm sure you know the fundamentals of managing lung disease in preterm babies. One big part of managing lung disease in preterm babies is to do no harm. And I think sometimes at least historically, the treatments that we would give would sometimes do more harm to the babies. They would do them some good, but they would sometimes do them some harm. And so I think we need to have a way of managing babies that does no harm. And the first thing is to have those oxygen limits that I mentioned before. And so we really should be, for preterm babies with lung disease, we should be trying to keep the saturation 88 to 95%. And that often means checking them a bit more regularly than we would otherwise. That can be with oxygen or it can be with CPAP. And CPAP can reduce the amount of oxygen a baby requires because many babies can improve their saturations by just having CPAP in air or very low concentration oxygen. I'll explain a bit about CPAP in my next slide. The third thing in terms of doing no harm to babies with lung disease, preterm babies with lung disease, is to improve their nutrition. And there's no doubt that enteral feeding can improve nutrition and improve babies' lung disease if you can effectively enterally feed them, and if you don't have to give them intravenous fluids. The use of intravenous fluids, I think, is sometimes necessary in the first 24 or 48 hours, but I try to get babies onto enteral feeding very quickly, even small amounts, and grade it up so that they're not exposed to the complications of intravenous fluids, which can make lungs wetter and make lung disease worse. If at all possible, you should keep the baby with the mother, because it's very important that the baby doesn't acquire hospital-acquired infections. And if the baby is separated from the mother, then it's a much greater chance that the baby will acquire hospital-acquired infections like multi-resistant Klebsiella or Enterobacter or these other multi-resistant gram-negatives than it is the baby will acquire their mother's bacteria, which is mostly lactobacillus and bifidobacterium, those healthy bacteria that keep the gut healthy. And so I'll speak a little bit more about this later, but an understanding of the microbiome of babies is very important, and how we can preserve the microbiome. So, and you might think that the gut has little to do with the lungs, but it actually has a lot to do with it. If you give babies intravenous fluids and don't feed them, then their lungs get wetter, and they get their lung disease takes a lot longer to resolve. So I think the way we manage babies, doing no harm and a very gentle approach to the management of acute lung disease in these babies is very important. In the old days, when we used to ventilate all these babies with high pressures, it used to damage their lungs, and they used to get much more likely to get bronchopulmonary dysplasia and complications. So we now try to have a gentler approach where more nutrition is provided, more CPAP, less mechanical ventilation. We keep within oxygen limits. We don't use intravenous fluids unnecessarily. We don't overload these babies, and we try to keep them as much as possible with their mother, and so that they can acquire a healthy microbiome. CPAP is, I just wanted to go through a little bit about CPAP, and I know you've had some teaching on this before, but I wanted to explain how relatively simple it is, especially for preterm babies. So this is a CPAP machine that we have used in PNG, and I think it's particularly good for preterm babies. You almost always get a CPAP effect. A CPAP machine is actually very simple. All it has is a gas source, and that gas source can be both oxygen and air, and you can blend the oxygen and the air. This is really important. You must not give CPAP with 100% oxygen in these babies. If you do, then they're much more likely to get retinopathy or prematurity. It's fine for term babies or for older children with pneumonia, but it's not good for preterm babies. That's why the CPAP concentrators have one dial that's air, and they have a gas source, so the gas comes out here. It goes through the bubble system, and is so through here the gas source comes out here. It goes through a humidifier, and for some of these CPAP systems now have a humidifier. It then goes to the baby. The inspiratory limb goes to the baby. The gas, the baby then breathes out against the expiratory limb, which goes under the water, right? And that's the amount of CPAP you're giving is the amount at which that the tubing is under the water. So if it's under the water for 5 centimeters, then you're giving 5 centimeters of PEEP, or positive end expiratory pressure, and that is around about what a preterm baby needs. And with that, you can reduce the fraction of inspired oxygen in a baby to a safe level. You need to, if you're giving CPAP, you can get away with giving less oxygen, and that can be helpful to these babies. I want to change tack now and talk a bit about nutrition in preterm babies, and how I think it's important to manage their nutrition. And the reason for that, preterm babies are always undernourished, and that's because in the first and second trimester of pregnancy, most of the nutrition that the baby gets through the placenta goes into organ development. So it's where the organs are forming and they're becoming developed. And so if a baby's born at the end of the second trimester, then they won't have any what's called accumulation or accretion of nutrients. So for a term baby, they'll have lots of subcutaneous fat and they'll have healthy muscles. But in a preterm baby, all of that nutrition has actually gone into organ development, their heart and their kidneys and their lungs, to help those organs develop. And so those babies won't have much in the way of glycogen stores in their liver. They won't have much in the way of subcutaneous fat or muscle tissue. And so babies born preterm are always deficient in nutrients, and we need to do something about that. So there's lots of, I think, risks, apart from what I mentioned about the prematurity, but there's lots of risks in prematurity to nutrition. And firstly, preterm babies have increased nutritional demand, so they're still in a rapid phase of growth. So they need close attention to their nutrition, both for organ development, organ maturation, but also muscle skin, soft tissue development. When babies are in a special care nursery or a neonatal intensive care unit, there's a lot of metabolic stress or biological stress on these babies, and that can use up a lot more nutrition. And sometimes when a baby's in utero, then they don't have to worry about temperature control. But when the baby's born preterm, then they have a lot of cold stress. And all of these stresses, these biological stresses and cold stress, increase the amount of nutrients that the baby requires. As I said, they have immature organ function. And so some of the risks of malnutrition in these babies relate to their immature gastrointestinal tract and the intolerance of feeds. As I said, the kidneys aren't well functioning in preterm babies, and they don't tolerate the normal solute loads or the normal loads that that a term baby would have. And they often have, preterm babies will, especially if they're small for gestational age, will have very little glycogen stores in their liver. So they'll often have glucose instability, and that increases the amount of metabolic work the body has to do, and therefore the amount of nutrition the baby needs. As I said, they have poor nutrient stores, and our nutrient stores are in our muscles, in our liver, in our subcutaneous fat, and the preterm baby doesn't have any of that. And they have altered feeding patterns. As you know, in a preterm baby doesn't develop a sucking and swallowing mechanism really until 32 or 34 weeks gestation. So there's lots of nutritional risks, I would say, in prematurity. There's a couple of fundamental things I think it's good to know for us all to know about feeding and calorie intake. And you may know this already, but these are just some facts that you should have at your, you should know if you're going to prescribe correct nutrition for these babies. Now, breast milk contains 70 kilocalories per 100 mils. All right, so each meal contains 0.7 kilocalories per meal. It's really important we know this, because that can help us understand the volume of milk that a baby can have or does need to achieve growth. All right, and we know that the energy goal for a preterm baby is somewhere between 130 and 150 kilocalories per kilogram per day. So that means their target volume, not where you start, but their target volume will need to be greater than that, because breast milk only contains 70 kilocalories per 100 mils. And so the volume to give you 130 kilocalories per kilogram per day will need to be about 185 mils per kilogram per day. That will give the preterm baby 130 kilocalories per kilogram per day, and that is the goal you're trying to achieve. You can't get there within the first day or so, and you shouldn't try, but it's very good if a baby by the end of the first week or 10 days can reach this target goal. Now that's a minimum target goal. Remember, the energy goal can be up to 150 kilocalories per kilogram per day. So often when we're feeding enterally, we need to give a bit more than that. But if you can get up to 185 mils per kilo per day within the first 7 to 10 days, then you're doing very well, right? And so if a baby's a 1.4 kilo baby, then you can calculate it out. 1.4 times 185 divided by 12 if you're feeding 2 hourly, or divided by 8 if you're feeding 3 hourly. So it'll either be 23 mils every 3 hours or 15 mils every 2 hours. Remember, that's 8 feeds a day or 12 feeds a day. It's not missing feeds overnight. You still have to feed these babies overnight. And so that can be the feeding goal. And as I said, if you can get there within the first week, then you know you're at least achieving the minimal energy goal for these preterm babies to grow and metabolize normally. The fluid requirements on day one are much less than that. They're nothing like 180 mils per kilo per day. They're around about 50 to 60 mils per kilo per day in a 1.4 kilo baby. Therefore, it would be 60 times 1.4, which is 84 mils over that 24 hours. So if you are giving intravenous fluids, it would be 3.5 mils per hour. Now, it's very hard for us to dial up 3.5 mils per hour with a burette, isn't it? And so really that if you're going to give intravenous fluids to a preterm baby, you really should be giving it with an infusion pump, a mechanical infusion pump that where you can dial up 3.5 mils an hour. Because if you're giving any more than that, if you're giving 5 mils an hour, that will be giving actually too much water to these babies. Or it could be 7 mils every 2 hours if you're giving enteral feeding. And I think it's good to start. I usually start a baby who's 1.4 kilos around about 2 mils every 2 hours. And then I increase fairly quickly, actually, if the feeds can be tolerated over 24 to 48 hours to that 7 mils every 2 hours. If you're giving by, as I said, if you're giving intravenous fluids, even as a part of that, you really should be giving by an infusion pump. So, because if you are giving 2 mils every 2 hours, you'd only be giving 2.5 mils. That's the intravenous fluid that's left, 2.5 mils per hour. And that's really hard to dial up on a burette. So ideally, you'd use an infusion pump, or if you don't have an infusion pump, then it's probably safer just to give enteral feeding with breast milk at up to 7 mils every 2 hours on the first day. And then your goal, you need to know what your goal is, and you need to see whether you can achieve that over a period of usually a few days to a week. But during that time, when you're grading up the feeds, you need to be looking for signs of feeding intolerance. So, and I'm sure you know these, but we every day when we do our ward rounds, we should be assessing each baby for signs of feed intolerance. And that involves asking, taking the history from the mother or the nurse about an increase in abdominal distension, or whether the baby's had any vomiting, whether sometimes people aspirate the nasogastric tube. I tend not to do that unless there's any other signs, because sometimes when you aspirate the nasogastric tube, you just get the milk that you put in, and that's okay to have some milk and some gastric juice in the stomach because we're producing gastric fluid all the time. I tend not to aspirate the stomach routinely to assess for residuals unless there's some other sign. If there's blood in the stools or increased abdominal distension, or if there's systemic features like apnea or bradycardia, then I usually aspirate the nasogastric tube. But otherwise, I don't tend to do that, because all it does is waste nutrients that the baby will eventually absorb. Now, if a baby had any of those signs, then having an X-ray is important. And I just wanted to you to have a look at this X-ray and see what you think. What do you think's going on here? This is a 1.4 kilo baby who commenced enteral feeding with expressed breast milk, and then was on some IV fluids, but not much, and then developed a bit of abdominal distension and some apneas. And this was the X-ray. Well, what do you think's going on here? Sometimes in older children, we might do an X-ray like this and see this type of pattern, and we might think, oh, they're a bit constipated, because it looks like, at first glance, it looks like there could be just a lot of stool in the bowel, but it's not stool. And I wanted you to see this this image because it indicates a certain condition. So does anyone know what it indicates? That's okay. I just wanted to look at the very small, it looks like bubbles. Can't you see all the tiny little bubbles, air bubbles all throughout the bowel? And you see this tiny air bubbles. So these are normal, these are relatively normal gas bubbles within the bowel. The bowel wall itself looks a bit thickened to me all over, but there are these tiny little gas bubbles all throughout. And this is a condition called pneumatosis, all right? So air in the pneumatosis coli, so air in the colon or air in the bowel. And of course, we all have air in the lumen of our bowel, but this is air in the wall of the bowel. And so these are all gas bubbles within the wall of the bowel. And this is necrotizing enterocolitis. And one of the signs of necrotizing enterocolitis is air within the wall of the bowel. All right, there's some other signs as well. So if you had a perforation, you might see some free gas outside the bowel. Sometimes you get gas in the biliary tree, so you can see the bile ducts outlined by air, translucency outlining the signs. And sometimes you get an X-ray that looks like this. So this is, again, I've just put some arrows here. There's air in the wall of the bowel. This is another baby who had necrotizing enterocolitis. You can see the air in the wall of the bowel. And this happens when babies have often severe feed intolerance. They may get an infection, and then infection may be produced with gas-producing organisms like Clostridia. It's a little bit like, it's a little bit like PBL in a way, but it's actually more common than that these days, that babies will get this. So as we are progressing in the feeding of these babies, we just need to be alert to any signs of feed intolerance. And if there's feed intolerance, then examine the baby and see if the baby's got a soft abdomen, or whether it's a little bit tender, or whether the baby looks like they're systemically unwell. And if they've got any concerning signs, then get an X-ray. If there's no signs of pneumatosis coli or gas within the wall of the bowel or free gas, then sometimes it's just okay to keep feeding the baby. But if there's a lot of clinical signs, like they've clinically looked like they've got NEC, or there's any radiological signs of necrotizing enterocolitis, then we have to rest the bowel for a few days and give antibiotics that would cover the common bacteria causing NEC, which is just, if you use penicillin, gentamicin, and metronidazole, you'll cover the common bacteria causing necrotizing enterocolitis in most nurseries. Okay. As well as understanding about the calories required, it's good to understand about how to assess growth in these babies. And so if, as a rule of thumb, if a baby is less than 2 kilos, then they should put on somewhere between 15 and 30 grams a day. So remember, if a baby's, a normal growth for a baby is about 150 grams a week. If they're putting on 100 to 150 grams a week, that's pretty good. That's quite good growth. But yes, 15 to 30 grams a day. And they should grow not only in weight, but also in length. And they should get somewhere between 0.7 and 1 centimeter per week in length. And their head circumference, this is very important, their head circumference should increase by somewhere between 0.5 and 1 centimeter per week. So it is important that we have these anthropometric measurements on babies, and we measure them at least once every week or 2 weeks. I think this is important for the follow-up particularly. Now, for preterm babies who are corrected to term age, so if they're like born at 32 weeks, by the time they get to 8 weeks, you can use the WHO growth charts as normal. You can use it corrected for term age. And it's important to know that these babies, they may, what you're looking for is the normal trajectory along the growth curve. And these babies can have catch-up growth even in the first 2 years. So if they're well nourished, then often they'll get, they will be crossing centiles upwards in the first 2 years. So even if they were born as very low birth weight babies, by the time they're 2 years, maybe they'll be a bit closer to, they won't have a weight that's less than -3 standard deviations or -3 Z scores. If they're gaining weight well, then they'll be crossing centiles upwards, so they'll actually gain some weight. And that can happen anytime in the first 2 years. This type of graph, that I've added here, is really for when they're preterm, and it can tell you where they fall within being either appropriate size for gestational age, or small for gestational age, or large for gestational age. This is more about their birth weight. But we should use the WHO growth charts for preterm babies when they correct to term age. You can start using the WHO growth charts at the time of the baby's born, but often the increments are too small to really graph the improvement in growth. And so it's important to have another way of measuring in their baby book how much weight they're gaining, and see and calculate whether they're gaining a good amount, 15 to 30 grams per day or more than 150 grams a week. That would be good. After you've initiated feeding on these preterm babies with express breast milk, then they do need some multivitamin supplements in the first 6 months of life at least. And so I start all these babies on a multivitamin, a B group vitamin, and fat soluble vitamins like vitamin D and E, and just give them 1 ml per day. I think preterm babies, like I said before, especially for their bone health, they need some extra vitamin D, so that can be useful. And I'll talk a bit more about this, but babies who are preterm always are iron deficient, and they're iron deficient because it's only in the 3rd trimester that iron is transported across the placenta from the mother. So in the first 2 trimesters, all the iron that is transported really goes for organ development rather than for iron stores. So babies that are born in the early 3rd trimester of pregnancy will have very little iron stores, but so they need iron supplementation from, usually we start at 4 to 6 weeks of age. If you start too early, then as you know, I think that makes babies more prone to get infections, certainly from infections like necrotizing enterocolitis and gram-negative infections. So I start all these babies, the preterm, very low birth weight babies, on iron supplementation around about 4 to 6 weeks of age. That's when it's safe to do so. I wanted to just talk about 3 longer-term complications of prematurity, and I wanted to talk about them because they, I think we see them quite a lot, and I found that as preterm babies, as you get more preterm babies to survive, then our job really as pediatricians is to try to minimize the risk of these longer term complications. And so one is chronic lung disease of prematurity, which I think we see quite a lot. And it's important to understand how to manage it. So the definition of bronchopulmonary dysplasia or chronic lung disease of prematurity is simply that a baby requires oxygen for more than 1 month, 1 month of life. If a baby is still hypoxic at 1 month of life and they need some supplemental oxygen, then they've got some form of chronic lung disease, unless of course they've got a cardiac reason for their hypoxia. But if it's because of their lungs, then they've got chronic lung disease of prematurity. And the treatment for it is really, I think some people have said if they've got chronic lung disease of prematurity, maybe it's not worth treating them because their lungs will always be bad. I don't think that's true. I think that many babies who have chronic lung disease can actually grow out of their chronic lung disease if you get everything else right. If you do no harm and you improve their nutrition and you manage their lung disease well and you prevent them getting lots of lung infections, then they can get lung growth, new lung growth within the first 2 years, and many years later they can start, their lungs can grow further. But it doesn't grow if their lungs don't grow if they get further damage from viral infections, from bacterial infections, from undernutrition, or they get TB or some other problem occurs. Then their lungs don't grow healthy. But if you can keep their lungs healthy, even if they just need a little bit of oxygen for a few months, then typically if you improve their nutrition, and then you can then they get lung growth. This point about the microbiome is actually really quite important. This microbiome that I was talking about, if babies are born in if babies are born in a hospital and they spend a lot of time in the special care nursery, then they're often colonized with these multi-resistant organisms. And we really, the more antibiotics they are exposed to, the more abnormal their bacteria in their gastrointestinal tract and in their respiratory tract are, the more abnormal they are. And so we really should try to avoid using antibiotics when we don't need to, because that's what disrupts the microbiome. We should be aiming to improve their nutrition with breast milk and avoid antibiotics if we can. Some of these babies respond to bronchodilators because they have chronic airways disease as well. And some of them respond to steroids, but we really should be not trying to overuse steroids because that will impair their other growth. It'll impair their metabolic function. And so I try to minimize the use of steroids. I mean, if a baby is really stuck without progress, then sometimes I use a short course of steroids to try to improve them. Or if they get an acute exacerbation, sometimes I use a short course of steroids, but I try never to have these babies on steroids long term because it worsens their metabolic function. They get more glucose intolerance. They get hypertension. It worsens their bone disease. So it really, steroids can really have a detrimental effect. And so I think it's important not to overuse steroids, and to recognize and explain to their parents that, you know, if the baby stays healthy and they grow, then often you get impressive lung growth in the first 2 years, and they can come off the oxygen and their lungs can be healthy again. But it all depends on whether we can keep their lungs healthy and do no further harm to their lungs. I wanted to explain a little bit about retinopathy of prematurity because it's something, again, that we all should know about. I won't explain too much about it because the ophthalmologists are the experts, but you need to know some fundamental things. And the first one is what it is. What is retinopathy of prematurity? And if you remember when I first, when I talked about the complications of preterm babies, one of the complications was interventricular hemorrhages. And you think, well, why do babies have interventricular hemorrhages? And it's because they have very friable, very fragile, very friable or fragile blood vessels. And when babies are preterm, then it's the same with their retinal vessels. With their retinal vessels, they have very fragile blood vessels. And we know that if they're exposed to a lot of oxygen, then they make new blood vessels. So new small arterioles proliferate on the retina. And that's because oxygen it stimulates angiogenesis, so you get abnormal vessel formation. And so in the retina is normally vascularized, of course. It normally has a blood supply. But when a preterm baby's been exposed to a lot of oxygen, they get what's called neovascularization, which is just new fragile vessel formation on the retinal epithelium. And that leads to leakage of plasma, it leads to bleeding, and it leads to fibrosis. And then eventually, if you've got very severe retinopathy of prematurity, then the retina is distorted, and that can lead to retinal detachment. If you think the retina should be a normal formation, if it gets scarred, if there's scarring, then that leads to distortion, and then the retina can detach from the its normal surface. And if the retina detaches, then the child will go blind. And so the degree of ROP, retinopathy of prematurity, depends on two things. This is what I want you to know. It depends on two things. The first one is the amount of new vessel formation and the consequences of that. So the leakage of plasma, the bleeding, fibrosis, and retinal distortion. So it's the severity of this process. It's all a continuous process of new abnormal vessel formation, plasma leakage within the retina, some bleeding, and then scarring. That's all a continuum of process. And then the second thing it depends upon is where it is, where the major lesions are. And there are three different zones in the retina. There's the middle zone, which is actually the zone where the optic nerve fibers are at their most concentrated. So most of our vision comes from here, where we've got the macula and the optic nerve coming in. And if you've got a bad ROP within the macula, then that's when children are more likely to be blind. If they've got only zone 2 or zone 3 ROP, and it's only of a mild degree without retinal fibrosis or scarring or distortion or detachment, then they may have only minimal visual loss. And so just to remember these two things. One, the continuum of pathology that occurs from just new vessel formation, leakage of plasma, bleeding, fibrosis, and distortion of the retina with retinal detachment if possible. And then the second part, which is the more central the pathology, the more central this process, the more their vision is lost. They're the things I think you need to know. And you need to know that keeping the oxygen saturation when you're giving supplemental oxygen, this only applies if you're giving oxygen. Keeping the oxygen saturation less than 95% is very important. We know the risk factors for ROP are not, they're not just giving oxygen, but other things too about the severity of complications. So the worse the retinopathy of prematurity, it usually happens in babies that have fairly bad respiratory distress syndrome, or they have anemia, or they need blood transfusions. These may just be indicators of how sick the baby is, but it's not just about oxygen. But hypotension and other infections and other things can also make a preterm baby more at risk of ROP. The complications of ROP can be relatively mild, but they in the postnatal clinics you can pick them up if a baby has like a lazy eye, if their extraocular movements aren't normal, or if they develop a squint, or if they have high intraocular pressure. Again, something the ophthalmologist should check for in all preterm babies, and of course if they have loss of vision or retinal detachment. So all of these babies should undergo visual screening in the first 6 weeks of life, but we should focus on the prevention, on minimizing the complications, minimizing the oxygen administration to these babies. I wanted to just briefly touch on anaemia of prematurity as a third complication. So I've talked about bronchopulmonary dysplasia or chronic lung disease. I've talked about retinopathy of prematurity, and I just wanted to touch on anemia of prematurity because this is so common, it's almost universal, that preterm babies will become anemic. And like I said, a big cause is that iron is transferred across the placenta only in the 3rd trimester, and it's not transferred earlier. And sometimes babies undergo some feto-maternal hemorrhage or placental abruption where they lose some blood around the time of birth. And then there's the things we do to the babies in the special care nursery. We might take blood from them, and every time you take some blood, you're also taking some iron, and so that can make them more anemic. We need to understand the signs of anemia. The signs of sort of clinically important anemia they're very non-specific, and they can be anything from like apnea and desaturation, or bradycardia, or a baby has an increased oxygen requirement, or tachycardia. These are all very non-specific signs, but they can be signs that the baby is developing anemia. We should prevent anemia by minimizing blood taking. All right, we should try to manage babies in a way that doesn't require a lot of blood taking, I think. And we should try to optimize their nutrition from the start. And we should try to give them iron from 4 to 6 weeks of age, because that replaces their iron. I've just listed here the sort of international consensus on what the threshold is for a blood transfusion. And the point is that the thresholds are a bit different for very, very low birth weight or preterm babies. Some people say that in the first 24 hours of life, if a very preterm baby, a very low birth weight baby under 1.5 kilos, has a hemoglobin less than 10, then they'd be better off having a hemoglobin of 12 or 14 grams per deciliter. If they've got chronic lung disease and they're oxygen dependent, I usually will consider a transfusion if the baby's got a hemoglobin under 8. So if they're 7 point something or 6, then I would transfuse them. But in a late anemia that occurs in a baby who's feeding well and they're stable, then I wouldn't transfuse them unless their hemoglobin's under 7 at least. I would do all the other things to correct their anemia by improving their nutrition and making sure they're on the right dose of iron and that sort of thing. So whether you transfuse or not depends on a lot of things: the acuity, the timing, and whether they require oxygen or not, whether they're stable or not, whether they're growing or not. And so that's a judgment decision that you need to make. But there are some international guidelines, I think, that can help us in that regard. I tend to stick to these guidelines. I think they're quite useful. What I'm going to talk about now, just towards the end, this is close to the end, but I want to discuss what I think we haven't really had properly, and that is clear discharge criteria for preterm babies. And I think the consequence of that is that often preterm babies are sent home without without any clear system, if you like. And we always say, oh, the nursery got busy, so we had to send the baby home. And sometimes they're sent home after less than a week, and they may only be just 1.5 or 1.6 kilos. And to be honest, that's not been shown to be safe anywhere in the world. And I think we need to have proper discharge criteria that are really safe and are proven. And I'll talk, I wanted to suggest some discharge criteria that are based on international recommendations, and I'll explain what the studies are that have shown these to be safe. So I think that babies need to be somewhere between 1.8 and 2 kilos. The closer to 2 kilos they can be, the better, but some babies are safe to send home at 1.8 kilos, as long as they're breastfeeding well, they're sucking well, and they're gaining weight. They need to be able to maintain their temperature. And so you can't send a baby home that you haven't checked whether they can maintain their temperature when they've got clothes on, when they're clothed at room temperature. If they can't maintain their temperature at 36 to 37 degrees regularly for a period of at least a day, then they're not safe to send home. They shouldn't have had, in terms of their respiratory system, they shouldn't have had apnea for 5 days. Some international guidelines say 7 days, but I think at least you should observe the baby. If they're still having regular apneas, if they have an apnea at home, no one's going to help them. I mean, they probably won't be managed as well as what they would in the nursery or with their mother in the hospital. So you should wait and see that they're not having apneas. And their oxygen saturation should be more than 90% on air, unless, of course, you're sending babies home on oxygen. And then ultimately, if they have chronic lung disease and you're sending them home on oxygen, then that's fine. They can, as long as their saturation is more than 90%, then that's okay. But mostly, we should make sure their saturation is more than 90% on air and not having apneas. We need to have a program of teaching caregiver skills. And I think this has been a bit lacking. But we need to teach mothers and fathers how to bathe their babies properly, how to care for their infant, how to recognize the signs of illness. I teach parents all these things, and I also teach them simple cardiopulmonary resuscitation, like how to deal with an apnea, for example. I teach them a bit about infant massage and positioning and stimulation. These are important so that the mother and the father get to know their baby well. Because I think that parents, they must be prepared, not just physically, but psychologically and mentally for the care of these babies, because they have a big responsibility when they take their baby home to care for them. So in that regard, communication from the time the baby's born is very important. We need to tell parents what they need to achieve before they go home, the milestones their baby has to achieve. And I think we need to make some assessment, if you like, of the social risks to this baby going home. So we send some babies home to environments that are not really suitable to look after a baby who's fragile and needs good care. And it might be because there's some social risk within the family. So we need to be sure that there's no social risk. I mean, things like alcoholism or domestic violence or drug abuse or even extreme poverty or families who are homeless. We really need to address those social risks with social work and other services before we think it's safe to send a baby home, so we're sure that they get the right care. These babies should have had the first doses of all their vaccines, of course, as I mentioned. It is safe to give BCG to babies from 34 weeks gestation. It's safe and effective, and hepatitis B, of course, in the first 24 or 72 hours of life. They should have a full examination, and of course they would have had, but you need to examine them for those complications of prematurity, including their eye examination and checking to see if they've got chronic lung disease and making sure that they're tolerating their feeds well. And you need to arrange follow-up. It's really important that these babies get followed up. So I think if we had discharge criteria for preterm babies like this, instead of just saying, oh, they've got to, they're gaining weight, feeding okay, let's send them home because the nursery's full, I think that will result in a lot of babies dying, actually, because they're vulnerable or they're going home to environments that are not safe. So let's have some discharge criteria for preterm babies and stick to them. I drew upon for these discharge criteria. I drew upon a couple of studies that have looked at this. One from Singapore and one from Spain. I think they're very good studies that have tried to understand the when is it safe to send babies home. In some studies, there are a bit more sophisticated discharge criteria than this, but I think we have to have the basics before we discharge a baby. And both these studies showed that earlier discharge, less than 1.8 kilos, even in Spain and in Singapore, was not really safe. It wasn't really safe unless they had nurses going regularly into the home to check on the baby. In some countries where it's possible to have a nurse going regularly into the home, then discharging under 1.8 kilos can be safe. But in most environments, that's just not possible. So if we stick to these discharge criteria, then I think we should really have these as a sort of standard, because otherwise we'll be sending a lot of babies home in vulnerable positions, I think. The follow-up of these babies, this is my last slide, but the follow-up of these babies is very important, and it follows from all the things that I've said, that we should be monitoring them regularly, every month at least, for their nutrition and growth. We should monitor their growth chart, their weight, their length, their head circumference. We need to monitor the mother's ability to give nutrition, because some mothers have limited milk supplies and they may need breastfeeding counselling or support, or even they might need some supplementation. And it's good to link them in with Susu mamas. I think you should check every month that they're on their multivitamins and their iron and zinc. I give these babies zinc because I think we know it reduces the risk of diarrhea in the first year of life. Their neurodevelopment requires, so the first thing is nutrition and growth. Second is neurodevelopment. So we should check their motor development, their visual and hearing, and try to detect these problems early and refer them to the correct people, so the ophthalmologists, or refer them for a hearing test, or really just note that they've got some hearing problems and try to do something about it. Early intervention, I think, is really important for parents to learn. Like I said, we try, before children are discharged, you should teach mothers about correct positioning when feeding, about stimulation, I teach parents about how to assess and as the milestones of development, because most parents don't know what milestones the baby should reach. Simple things like when they smile, or when they can sit up, or when they can reach for objects, just simple things. We should teach mothers and fathers about their milestones, because when they do reach those milestones, they'll be proud of them, and they'll realize it's because of the care they've given at home. So we need to involve parents and fathers and mothers in the care and monitoring of these children. When we started getting more very low birth weight babies to survive many years ago in Goroka, we've previously had mortality rates of about 2/3, 66%, I think it was, and then we improved the care of these babies, and then more than 2/3, so 66% of them survived. We found there was a lot of infectious disease morbidity in the first year of life, and so these babies are more prone to pneumonia and bronchiolitis and diarrhea in the first year of life. But you can minimize that by making sure their lungs stay healthy, their nutrition is improved, they have their vaccines, their parents know how to look after them, and I think we can protect babies against these infectious diseases if we're aware that they can cause problems in the first year of life. So we need to, these 4 things should be monitored at least every month for these preterm babies, and then I think we can have some quite good outcomes. So remember, as I said at the start, it's not our aim just to get these babies to survive, but actually to thrive and to thrive and to be healthy and grow and have good outcomes in every way. That's all I wanted to say today, but I hope that's given you a good understanding of preterm and very low birth weight babies, and I'm happy to answer any questions that you might have.
Well, thank you very much for the presentation. I just want to ask how long or what is the duration that is recommended to follow up these preterm babies?
Yeah, that's a good question, Carol. Thank you. I think you need to follow them up for at least the first year, and sometimes to well into the second year. The frequency at which you follow them up doesn't have to be as often, does it? And I would say in some places, we would follow them up for right up until they go to school, and even after that, depending on any problems you see. And I think it's a good idea to follow them up for many years, but you don't have to see them every month. As they get into the second year of life, you might only see them, every 3 or 4 months in the second year of life, and maybe after that, until they go to school, every 6 months, depending on the complications they have. If they've got, chronic lung disease or they've got neurodevelopmental problems, obviously you'll see them earlier. But I think monthly for the first year, and then maybe 3 or 4 monthly for the second year, and then every 6 months thereafter until they're at school, but a bit more frequently if you detect complications. Does that make sense?
Thank you. Yes. Thank you, Prof. Thank you.
There are some good studies, that have been done looking at these babies, and they followed them up for, even up to the age of 18, and seen what their neurodevelopmental outcome is and their school performance is and that sort of thing. And I think we certainly should follow them up until they're going to school and doing well. Yeah.
Thank you.
If we do, sorry, I would just say, if we do have a follow-up process like this, I think it also is important for research and data, because we actually understand what the outcomes for these babies are. That's really the only way we've fully understood the outcomes for very low birth weight babies in other countries, like in Australia. Because they're followed up for so long and it's documented, it's like a longitudinal cohort study where you can follow them up and you can see what their outcomes are. It's very important, because we should know, what proportion of these babies develop, chronic lung disease, or what proportion have neurodevelopmental problems. We should be able to say that from our population, our cohorts. Yeah. Okay, well, I'm sorry this has been a bit longer lecture than normal, but I hope it's been useful. I know there's a lot to cover about, low birth weight and preterm babies, but I thought it would be useful to just talk about all of those problems today. If there's no other questions, we might stop. But if you have any other questions, please let me know.
Well, just want to ask about heavy fluids in there's a practice that sometimes we think of adding, for example, in day one, we usually give 60 mils per kilo per day, but then there's also a practice that we have to add the extra 10 mils. Do you still recommend that, or what do you say about that?
Benson, you mean an extra 10 mils of IV fluids, or an extra 10 mils of enteral feeding?
Yes,
or what?
Instead of 60 mils per kilo per day, it becomes 70. I think in a very low birth weight or extreme.
I don't think I'd do that, Benson. I mean, you could do that, but I don't think so, because I think 60 mils per kilo per day, if you also add some enteral feeding on top of that, then that's acceptable. But I wouldn't give more than 60 mils per kilo per day, because I just think, the problem we run into is like, RDS that gets worse in the first 24 or 48 hours, doesn't it? Eh? It usually gets worse. The lungs get a bit wetter. And if we contribute to that by giving more IV fluids, then you don't know whether, the IV fluids you've given is making the RDS worse. And then we give diuretics. And so it's a bit crazy, isn't it, to be giving IV fluids and then be giving diuretics to dry the lungs out. I think we should try to, stick to 60 mils per kilo per day for the first day. Of course, increase after that, but then try to get that IV fluids reduced so that the babies are enterally feeding a bit more. Does that make sense?
When do we change from 10%, or how long do we use the 10% for? Because sometimes some babies need IV fluids up to more than 7 days.
Yes.
So how long do we use that 10% glucose, normal saline with 10%?
Yes. I would keep going with it, Carol, because I think that you should be, when you're reducing the amount of IV fluids you're giving, if the aim is, yes, they need it after 7 days or maybe up to 7 days, but throughout that week, you're reducing the amount you're giving. You're also reducing the amount of glucose they're receiving. And so even if you're giving 10%, the amount of glucose is actually reducing, isn't it? So I would just keep it going as 10% for preterm low birth weight babies, unless they're developing hyperglycemia, which is actually pretty uncommon. But if they were, then you might reduce it to 5. But I in all preterm babies, I would keep it going at 10% glucose. Yeah.
Oh.
Yeah.
Good afternoon, Prof.
Oh, Betty, hi.
Hi. I just wanted to ask, in terms of multiple pregnancies, so like twins and triplets, are the Dubowitz and Ballard scores still as accurate? Because sometimes we tend to treat, just because they come out with weights of 1.8, 1.6, we may treat them as premature babies. But I just wanted to get your views.
Yes, it's just the same, Betty, because the Ballard score is independent of whether it's a multiple pregnancy or not. It's really based on the neuromotor function and based on the the external features, which are I think you can use it for twins or triplets or whatever. Yeah.
Thank you.
Sorry, Prof, one last question from us then. Yeah. I think we are done, sorry. It's just, this is regarding the extra calories that preterms they might need. When I was in Vanuatu, I saw that they were adding coconut oil into the breast milk. Yeah. Is that what you would recommend as well? For extra calories?
Yeah, look, I think, thanks, Carol. I think it's a good question. I mean, I certainly wouldn't give coconut oil as a, as a staple. Like it should only be added to breast milk. And I think it should only be added if the baby's failing to thrive and the baby's tolerating feeds. Because if you put anything foreign in like coconut oil or any other sorts of artificial formulas, the risk of necrotizing enterocolitis is higher. But if a baby's not gaining the sort of weight, reaching the targets that you want them to gain, and you want to fortify the breast milk, yes, then I think adding some coconut oil is actually a good idea. And it doesn't need to be much to increase the energy content of breast milk. So yes, but I think it's a good idea, but only if a baby's not gaining the weight that you want them to gain on breast milk alone, and only if they're tolerating their feeds adequately. I think that's what they do in Vanuatu.
Thank you.
Thank you, Prophet. Can I ask one last question?
Yes.
We've been teaching KMC here in NRH probably since 2018. It was introduced by WHO. So what do you recommend? We find it a bit helpful.
Yes.
And it gets us to discharge our low birth weight or premature babies early.
Yes, I think it's a very good thing to teach, and it, for all the reasons that I mentioned about keeping babies with mothers and improving feeding and reducing the risk of multi-resistant organisms and reducing the risk of hypothermia and an abnormal microbiome, and improving bonding between mother and baby. KMC is a really good thing to do, and it can also be reproduced when the baby's at home. And I think some mothers, they may or may not want to do the full KMC protocols, if you like, but you're trying to encourage skin-to-skin contact, aren't you? That's what you're trying to do with KMC, and that will have a beneficial effect. And I think you're right that it reduces, it can enable babies to get home even quicker. Yes.
Thank you very much.
All right, well, I'm going to stop the recording now.